It's The Journey with drug and alcohol attorney Mark G. Astor.
Well, all right, great. Welcome everybody to another edition of The Journey Live. Friday, 5 o'clock. I'm really excited to have my good friend Klay Weaver here with Dr. Dan Bober. Klay is the CEO of Life Skills, one of our very favorite treatment centers, and Dr. Dan Bober is the medical director at Life Skills. So thank you both for coming in.
Great, thanks for having us.
Thank you for having us. Definitely.
You know, we've done a lot of work with you guys, so I was flattered that you agreed to come in and chat with me. So maybe we could start with Dr. Dan, because I think you're the more educated out of all of us here. Klay tells me, my brother's a board certified doctor, but he says you have like 4 board certifications. So maybe tell us a little bit about what your background and training.
So I'm board certified in general or adult psychiatry, child and adolescent psychiatry, forensic psychiatry, and addiction medicine. And I'm currently on faculty at Yale University School of Medicine. I actually just got back from there, where I teach in the Child Study Center. And I do, a lot of stuff on TV, a lot of psychoeducation, especially about the stigma of mental illness and addiction. So it's something I'm very passionate about.
Well, and Klay?
Sure, he's a great teammate to have, right?
How about that?
It goes downhill.
One of them on my
this.
team.
Yeah, really. So my background's been working in community mental health centers, mostly in Georgia, running 2 of the largest systems in the state for over 12 years, and then coming into more boutique services where you do work with people more on one-on-one settings, working in smaller treatment centers where you have the funds to really provide holistic treatment for someone who needs it. It's been a good journey.
Wow. So how long have you both been at Life Skills?
Dan's been a little longer than I have.
I've been at Life Skills about 6 years now.
Wow. Okay. And Klay?
And I've been there 4 years. So.
Wow. And I know a lot of your stuff also. I've had a lot of time in there. It's not the kind of place where people rotate in and out quick.
No.
Well, so Dr. Dan, how can I call you Dr. Dan? Is that okay?
Call me anything you want. I've been called worse.
Well, I'm a lawyer, so nobody can beat that.
Right.
And trust me when it comes to getting
sometimes it doesn't even sound like my name. So.
So I mean, how'd you pick that area of practice? Because I know from my brother, who he works at a hospital, and he developed a real passion for critical care. When my father was sick, and he was in the middle of med school, and he realized that's where he wanted to be. So I mean, because you obviously got to be passionate about what you do.
Well, I think it's the opportunity to speak for people that don't have a voice, and in an area that again has a tremendous stigma. When someone tells you they have depression, you don't look at them the same way as if they tell you that you have diabetes. I mean, it's still seen as a basic character defect, a weakness of some sort. So I feel like until we come to the time when psychiatric illness can be viewed as a legitimate medical illness, just like every other medical illness, I still think we have a ways to go. Yeah,
it's interesting because I know just from sort of a non-clinician point of view, because we only do this kind of work. So we get most of our clients are probably a bit like yours. The parents are out of state. Their loved ones are here. So and the interesting sort of dichotomy is, especially sometimes you get one parent will say, well, why don't they just stop? And I think it's only recently, right, with the ability to sort of look at the brain, we've understood it's a brain disease.
Right, it's a brain disease, and I mean that's the neurobiology of addiction. I mean, it gets to the point where the addiction hijacks your brain. And, your brain is basically saying, use or die, use or die, use or die. So you're going to use that drug at the expense and at the detriment of everything. You're going to put your family relationships aside, your career aside, everything. You're willing to sacrifice everything. And that's why it really is a disease of the brain. And it's not just simply a choice or a character weakness.
So where do you think it all starts from? Is there a certain genetic component? Is it nature? Is it, somebody who maybe is predisposed and, for shits and giggles start smoking marijuana with their friends when they're a teenager? Or is it maybe all of those things or some of those things?
Well, I think there's definitely people who have genetic propensity for addiction. And then there are people that, those people start using it casually and then it becomes an addiction. But then there are some people who, they just dabble in it and they never use it again. So it really just depends on what your individual makeup is.
Yeah, so, let me ask you this, and I'm going to turn to Klay. So one of the things that we've seen a lot of is we see, when we're filing, especially with the Marchman Act, even the guardianships, we try to get a real, I call it triage in the case, and I got that from my brother, really trying to get into the history of what's been going on there so you can understand sort of the dynamics. we see a lot of kids who are maybe at 10 or 12 years old, or sometimes younger, at some point have been prescribed a medication for ADD, ADHD, or whatever, some of those, I don't know, disorders that they...
Attentional disorders.
Yeah, and that, I guess what I want to know is there some kind of link there? Because we see a lot of it.
So there is actually a link. So it's interesting. People who have untreated ADHD are actually at higher risk to develop substance use disorders. So that's one of the things we struggle with now, even at Life Skills, is, we have clients that come in and say, oh, I need my stimulant, I have ADHD. So what we do that's unusual compared to other centers is we test everyone for ADHD to make sure that they have bona fide, legitimate ADHD. Because otherwise it could just be another addiction. They want to use stimulants now. So it's tricky, but it requires a nuanced level of sophistication to try to tease apart who has an actual illness that requires treatment and who's just trying to use it recreationally.
And I would imagine, and you guys Klay probably sees this through admissions, that you probably get a lot of people who come in and maybe they went to see somebody who was perhaps not competent.
Or a little bit liberal with the
how about
medications?
That was what I was going to say. But, I've learned thing with doctors and lawyers, you got to be, I don't want to insult them, especially one who's far smarter than me when it comes to these issues. But yeah, we see that a lot, and I've got to believe that you probably see it too at admissions there.
You see it often. You see people drug seeking, even though the family's forcing them into treatment or coercing them into treatment. So a family's saying you have to go get treatment, or we're going to withhold funds, or we're going to take your car away. So people in some ways are being forced into treatment, and so they're coming in and they're then trying to game the system. Now they're thinking, what can we do if we're being forced into treatment? What can we do to continue with some of these?
One of the sayings I have is, how can you tell when an addict is lying, which is their mouth is moving and sound is coming out. So
I think that's very close to one of the lawyer jokes I've heard. It's the same ending, but just
right. So the point is that it's not about their character. They're not bad people. They're just people who are ill, and that deception and that self-deception actually is part of the illness.
Right. So do you think that sometimes these medications, as you point out, if they're sort of liberally prescribed, can trigger things? Because
I do think that sometimes medications can make it worse, and our motto at Life Skills is always skills, not pills. So I always tell people, if you can try to do it with therapy first, you're better off, having the skills which will endure over time versus just trying to throw a pill at it. I think it's just there's a westernized mentality that there's a pill for everything. There's a pill to get hard, there's a pill to concentrate, there's a pill to lose weight, and no one wants to do the work. And so I think acquiring the skills is going to be a lot better for them long term than just trying to throw a pill at the problem.
Wow. So Klay, how long's Life Skills been around for?
Yeah, Life Skills, this is our 28th year of business.
Wow.
Been here a long time. Interesting, Life Skills started as a addiction treatment center 28 years ago that specialized in dealing with underlying issues, specifically trauma. And that was the beginning of Life Skills. And then over time, the leadership group at Life Skills realized that there are many other underlying issues that contribute toward an addictive personality or addiction. And over time, Life Skills then began adding other clinical pathways to its treatment, dealing with mental health issues.
Yeah, that's one of the things I know that I know from our perspective. One of the reasons we love you guys is because you can treat both as primary, which is really important. I mean, Audra's side of the practice, which deals with the mental health sort of component, where it's primary or maybe just standalone. I mean, it seems like when it comes to substance use, we've got this probably a much bigger selection of potential places they can go for treatment. But when it comes to mental health issues, the choices are very sort of slim and narrow.
Right, and that's something you don't see in a lot of treatment programs, and it's something that we really do well, and it's our bread and butter. Is you'll see programs that are sort of substance abuse heavy, mental illness light. We are absolutely all the way, hands down, mental illness heavy and substance abuse heavy. I mean, we see people with severe mental illness. We see people on Clozaril. We see people with treatment-resistant depression who've had ECT, people who've been in the state hospital. So we really take the very, very tough cases that a lot of other treatment centers turn away because of our expertise at dealing with that level of severity.
Yeah, one of the things that I always say that when we get calls, it's like going to the dentist. Nobody ever wants to go to the dentist. Nobody ever wants to call a lawyer. So they typically call us as the last resort. And I'm always amazed that, we're seeing 5, 10, 15, 20 years where someone has been dealing with this issue for so long. And I'm just wondering if somebody comes in and they have been, using, having mental health issues for 5 or 10 years. I mean, how long does it even take to get that person stabilized before you can start to sort of, reverse things?
Well, it does. It really depends on the situation, but we try to encourage people to stay at least 3 months because it takes that amount of time to form those new associative connections in the brain. The brain is hijacked by addiction, right? So there's this part of your brain called the prefrontal cortex. It's involved in what we call organizing, planning, executive functioning is what we call it in the field. That is the part of the brain that sort of thinks things through and says, wait, stop, I need to think this through before I do it. And that is the part of the brain that is sort of offline in full-blown addiction. You're all about what we call the limbic system. You're all about emotion and reaction. You're not really thinking it through. So it takes time to get that part of the brain back online where the thinking or the wise mind is actually functioning and not just the emotional mind.
Wow, that's because sometimes families will say to me, well, if I send them to treatment for 30 days, will that take care of things? And I'm like, well, look, if you had cancer, right? If you had cancer and you'd been, sick for 2, 3, 4, 5 years, I mean, you wouldn't do chemo for 30 days and say, oh, I'm healed.
We use that metaphor almost every day with families we're dealing with, and as they're like, can we just come in for 30 days? And well, you can go someplace for 30 days, but you would not ask that question if you had stage 4 cancer. You're going to see an oncologist. You'd not be saying, can I just do 30 days of treatment and be done? You'd be asking for a complete treatment plan that would get you from point A to point B, from sickness to wellness. You would not want to stop short. But somehow with brain disorders, many family members too are tricked into thinking that there's an easy cure, an easy fix.
Yeah, and maybe that's because when somebody has cancer, they sort of look sick, right? Somebody who might have a mental health issue, I mean,
maybe they act sick more than they look sick.
Right, thank you, yeah.
Right, so
they might look visually okay.
There's contributing to the stigma again, so we look well on the outside.
So everything must be fine.
Everything's fine, yeah. Right. They can put a tie on, they can clean up, they can pull it together for brief periods of time, moments of time, but they cannot continue in continuous sobriety. They make poor decisions. Good decisions followed by a bad decision, and there we all. The cycle continues.
Yeah, I'm gonna ask you. I have just thinking about it here. We get a lot of kids that have been smoking marijuana. I know when I was a kid growing up, I never actually smoked, but I had a lot of friends that smoked, and maybe one or two, went off sideways. But for the most of them, I think I still have friends I went to law school with that still like to smoke, but. It just seems like the drugs today are so much different from what we all knew growing up. I mean,
so 30 or 40 years ago, the THC content of marijuana was about 2%, and now it's about 20%. So we're actually seeing actual cases of cannabis addiction and cannabis withdrawal in a way that we never saw it before. The classical thinking was it's just psychologically addictive. You just get a little buzz and you move on. But now we're actually seeing people who actually have withdrawal, and worse. Cannabis is an independent risk factor for psychosis. So we're actually seeing people who are having permanent psychosis induced by cannabis in a way we never saw before because it wasn't as strong back then.
Yeah, and when we get these cases where there's marijuana smoking, they seem very consistent. Paranoia, delusional. They think everybody's out to get them. The CIA and the FBI are watching them.
Absolutely.
The TV's watching them. The
That's
computer's
the
watching them.
cannabis-induced psychosis.
It's really scary. And I'm like, wow, this is, And the other thing that I've heard is that, I guess between up until the age of 25, the brain is still forming. And so if a kid as a teenager is smoking a lot of marijuana, I mean, it could do they say it can affect the IQ.
Yeah, it can actually affect their IQ. It can affect their working memory, their concentration, their motivation. Marijuana, that's one of the real big downsides about legalized recreational marijuana, is that by making it so ubiquitous, you are essentially saying it's socially acceptable. And so you've got all these kids who have developing brains that are using marijuana that are actually doing damage to their brains.
Wow, that's frightening. Are you guys seeing a lot of that over at Life Skills with the marijuana use?
Every day. We see a ton
Daily.
of it. Yeah. It's something, it's like drinking water. We see it every day.
Well, a gentleman that Dr. Bober and the treatment team was working with just recently here locally in Florida, a very well-to-do family. The child was a typical young adult you hear about, living in the basement, not motivated, smoking marijuana daily, but also having severe hallucinations and delusions. and they think it's just a motivation issue, but now it's gone from initially what could have been motivation, but we're now dealing with someone who with full-blown psychosis, and it's not temporary. They have a psychotic disorder.
So what do you do in a case like that? What can you do?
You try to treat it with antipsychotic medication, try to get them stable. And again, it's just like diabetes. It may never go away, but you could get it to the point where you can control it and it can be stable and they can lead a productive and functional life.
Well, so how do you measure things like that? Because it's not like, I mean, can you, we can take blood, right, and we can figure out what someone's cholesterol and all the things that are going on within our bodies. But something like that, which is a brain disorder, how do you measure something like that?
Well, you look at the objective measures, right? Are they able to hold down a job? Are they able to go back to school? Are they able to, have good ADLs or activities of daily living? So you're looking at the clinical signs. Yeah, of course, there are rating scales that you could use, but the proof is in the pudding. How are they actually functioning? You can do psychological testing, but at the end of the day, is this someone who's able to live independently and function in the world?
Wow. Okay. So now the other thing is when Audra and I were at a NAMI meeting, I don't know, probably about a year ago. They had a professor there from Nova, and he was saying, sometimes when you're prescribing a medication, you don't always get it right the first time, and if you do get it right, sometimes that medication can wear off, and you got to switch to something else. So
that's also true. One thing we do at Life Skills is we do genetic testing, or pharmacogenetic testing, to help determine which drugs will be metabolized better. So it's one tool in the toolbox. It's not the standard of care, but it's the gold standard, and it's something that we do to try to help determine which drug will work best, or at least which ones we should try to stay away from.
Right. Wow. So where do most of your families come from? Are they from Florida? Are they?
Yeah. Our biggest majority of our families historically are from the northeastern corridor, so that the New England area. Florida has a relatively large percent, but the Northeast is the largest. We've had clients from almost all 50 states, so national and international.
Wow.
And referrals from all the top centers, Harvard, McLean, Menninger Clinic, the Linder Center, Silver Hill, all the, top places. We're fortunate enough to get referrals from them.
Wow. So tell us a little bit about your team, because just the fact that you have...
So
the good doctor here,
the
as your
good
medical
doctor.
director. I mean, that's honestly. I mean, look, when I first opened up, I spent the first 2 or 3 months just going to different treatment centers. I want to know what does it look like, who's the team, who owns the place.
Yeah.
And obviously over time you learn the process of reputation. But I mean, just to have a medical director with that kind of background is really, frankly, unusual.
To give you an idea of who he works with on a daily
I got
basis.
doctors in the family. Audra has a family full of doctors. Her father, her brother, and her brother-in-law, and my brother and my brother-in-law. So don't worry, I'm surrounded by doctors.
Full
you're
of
always
physicians.
covered if there's a medical issue.
I'm pretty much covered.
Good.
And now if I have a mental health breakdown,
Yeah,
You're
covered.
You know who to go
guys.
to. You know who the expert is.
If you ever lose your mind, I'm right here. Right.
Yeah, so every year, U.S. News & World Report does a ranking of the top medical facilities in the nation, and they do them by category. And the one category for psychiatry and brain disorders, Life Skills and Dr. Bober, we've worked with 8 of the top 10 centers in the nation. So that's who he works with on a daily basis. That gives you an idea of where our families and referrals are coming from.
Wow. And what about the team members? I've had, obviously I've had the opportunity to come down and meet your team. It's pretty unusual.
Our model's a little different. We're led by, obviously, Dr. Bober, Yale trained, Ivy League trained physician with multiple board certifications. But our model with the clinical staff is very similar. The majority of our staff have PhDs. So we're not just hiring people with a bachelor's degree or just a master's, but they have PhDs and
Doctoral level clinicians.
Doctoral level, and they're licensed. Additionally, we also look at evidence-based best practices, which if you're familiar with SAMHSA or National Institute of Health, where in all areas of medicine we are tracking outcomes to see which treatments have the best efficacy. So at Life Skills, we're following evidence-based best practices in our clinical pathways, and we require our clinicians to become nationally certified in those areas of our expertise. So we're not your typical treatment center in South Florida.
I don't know that because most of the time I got to call and beg you to take one of our kids because you're always full.
It's a problem. It's a good problem,
It
but
is
it
a
is
good
a
problem.
problem.
But it is, yes.
It is a problem.
Yeah.
So we do try to triage the calls that come in, and so we try to get prioritize to people that we work with, referral sources that we work with, to get their person in more quickly, as opposed to just a random call or someone on the internet. So we do things to prioritize and get them in.
Right. So I know I've been to the Deerfield campus, and it really is a bit like a campus, right? I mean, you've got a pool in the middle, and there's sort of the housing, and then the clinical side. And so how at any one time, how many people do you have that are in treatment with you guys?
Sure. We have counting, well, at residential, 50. We have 50 beds, and we are routinely full at 50 beds. We also have another 40 people that are in treatment with us in PHP and IOP levels of care, and they're also in our transitional living houses.
So maybe we could talk about a little bit of the different levels of care, because that was one of the things that when I first started doing this kind of work, I had to sort of figure out. Right. So maybe, because there's going to be a lot of parents watching this.
Sure.
Explain maybe the different levels of care.
So the different levels of care. So the residential level of care would be more like the individual that we had spoken about, the patient who needs real stabilization. They need real medication adherence. 24/7 monitoring. They need to build up their skill level to begin to take baby steps reentering life. So there's that level of care. And for us, that's about a 90-day stay for most people. The next levels of care we have is a day program, or PHP level of care as it's referred to. That level of care, again, is where someone can live independently or semi-independently in the community and still come to treatment 5 days a week for the entire day. So we have that level of care. And then there's the IOP level of care, which is 3 days a week, 3 hours of treatment per day. So it's for people who at that point are ready to reenter one of three areas of living skills, are ready to reenter education, employment, or volunteerism. So there may be some people who are dealing with chronic, ongoing thought disorders, psychotic disorder, but they're stable. They may not be able to hold down a job or go back to school, but can they do some daily living activities that are meaningful and go into volunteerism so that they have a meaningful life. So we want them involved at that level in one of three areas. So we don't want people who are stable yet chronic just sitting at home. We want them to gain meaning in their life.
Right. So how do you make the determination as to what level of care? Because most of the time, especially with the work we do, the involuntary commitment, that they're going into residential. They need that level of care. But sometimes you get a set of parents say, "Well, I'm not. I don't want to put my child in residential. There's a number of different reasons. I'm sure financial has something to do with it. Like, no, we'll put them into PHP." And meanwhile, the assessment has said, no, you need residential, and it is nearly always an absolute disaster because it's not intense enough to start the process. So how do you figure out who's going where?
Well, we're always upfront. We're always transparent. We tell people this is the level of care that we think your loved one needs. And they say, well, I can't afford it, or I don't want to do it, or I don't want them living somewhere. Then we say, okay, well, let's try to work with you. Maybe we'll put you in PHP and see how it goes. But, we're very upfront with them about our clinical recommendations from the beginning. And, we tell them, look, this is the place where, success has the highest probability. If they're at PHP or IOP, they may not do as well because they need that structure and it's lacking here. So we try to tell people up front.
Well, so go ahead. I'm sorry, Klay.
Yeah. So practically, how that would play out if a family is talking with us about their loved one being in treatment, and it's a local family, and they're like, we want them to live with us. Oh, but that's where they smoke pot every day, all day long in the basement.
The triggers are there.
Oh, the triggers are there. All of those influences are right there in there. So that's not going to be an appropriate level of care for someone to get what they need while all those influences are still around them, or their friends live around the corner. And their friends are playing a role into their use, or they're living at home and they cannot take their prescribed medication as they should. So they may take it 1 week because they feel like it. The next week they do not want it. They don't feel like it. So that's not an appropriate level of care for someone to go into treatment and live in an environment where they're not medication adherent. So
and sometimes it's a setup for failure.
Yes.
And we tell the parents that right up front.
Wow. So let's say hypothetically a family calls, they're from New York, right, or the Boston area. They call you and they say, hey, we found you online, or we've heard about you, we were referred to you by a clinician. So how does the assessment process work?
Yeah, so it comes in through, calls can come in through many channels, but it'll come in through the admissions department, and then we'll do an assessment. One of the admission coordinators will do an assessment. We also have nurses in the admissions department, so there'll be not only a clinical assessment, but nursing will be involved.
Do a medical screening as well.
Dr. Bober's involved, and so there's a group of people that all make that decision. Is that person appropriate for life skills? What level of care should they be involved in? So there's that group making that decision.
Okay, yeah, it's important.
But they're dealing with one person up front, so there's one admission coordinator with a team behind them as that
Point of
decision
contact,
is made.
yeah.
Wow, it's impressive stuff. So let's talk about my favorite subject, which is the Marchman Act. And actually, I guess my second favorite subject, which is the guardianship. If I don't talk about that, my better half is going to.
Yes, you better do that.
I'm going to have something to say about that. So let's talk about that, because we obviously that's sort of where we've all worked together. So, and I know we didn't talk about this off air. So occasionally when I ask this question, I get the answer I didn't want to hear. But let's talk about how you and how we work with your team, either with a guardianship or a Marchman Act, how that
Sure.
sort of works. So let's talk about what your feelings are on the whole idea of involuntary commitment, because mums and dads will say, well, I don't want to force I'm not forcing my child into it. Most people don't want to be forced, and everybody's resistant. People don't like to do what they've been, when there's that sort of internal struggle going on, they don't want to do something. And I say, look, I don't want to force your child to do something. But if they can't make the decision or won't make the decision, who's making it for them? Somebody has to. Are you willing to make a decision for them they can't make?
You know what? It's always a balance between public safety and an individual's right to have self-determination and autonomy. But there are certain cases where their insight is so poor and their judgment is so grossly impaired that they are not able to make those healthy decisions. And unfortunately, at some point, someone needs to make them for them.
Yeah, and that's the way we feel. And
so when you're talking with a family, I mean, how that plays out practically, if their loved one has multiple overdoses, in and out of an emergency room, they've almost died, then the family has a decision there. I mean, this person is literally one bad purchase of a drug that's laced from no longer being around in this world. So those are decisions that
literally
parents,
a life and death situation.
Yeah, it's life and death. Now, if someone is, maybe they're just, they're one of these failure to launch, they're at home in the basement, they're smoking marijuana.
Failure to launch, I love that.
Yeah,
right.
you can make it.
Smoking marijuana,
yeah.
playing,
video
games all
exactly,
day.
Yeah.
I'll tell you something, when you get, I took me a while, but when I realized I didn't have any money to pay my own bills, believe me, I launched.
Right.
And then you went to law school. So it all worked out.
Yeah, how about that?
So those are the ones you go, okay, maybe those you can work with the family and you can bring them some skill level where they can deal with it. But maybe they wouldn't consider Marchman at that level. But for someone who really has ongoing health issues and they have poor decisions and they are just very fortunate to not have died in an emergency room or in an overdose, then we would look at those different. If my son, I would look at it.
Actually, your son's in med school as well, right?
Yes, I have a son who is in
Who's going to psychiatry.
second year of residency, going to be a psychiatrist. So if he were using drugs and his life were in danger, and I was watching him make choices that put him at risk of dying every day, then as a parent, I would want to have that option. I may not want that option if he were a failure to launch and he's just shuffling around. I may deal with it differently. But for someone who's putting their life at risk, they don't have the capacity to make those decisions, the Marchman is an excellent tool.
Yeah, and sometimes I know that we'll sort of work the process. We'll sort of get involved right at the beginning, right, where that the parents have made a decision to get their kids into treatment, or sometimes it can be in the middle of things, right? I've noticed that sometimes someone becomes treatment resistant, or I know sometimes on the mental health side, if there's been a Baker Act and now we're really concerned that they're going to leave or they need an injectable, something like that. So it just seems like it's not always set in stone as to when it's going to happen or why it's going to happen. So
yeah, everyone is a unique individual, and every case has its ups and downs, and you just have to take it, one person at a time to determine what's best for them.
All right, so I'm going to cover two other areas with you because It just sort of dawned on me because I feel like I'm so lucky to have Dr. Bober
You have
here.
our team. You have our clinical team leader
I'm going to pick
here.
his brains while he's here because I may not be able to get an audience with him again for a while. So over the years, have you seen things sort of start to things get worse? I mean, I know we've been busier every year we've been open doing this kind of work. Are you guys, is the demand for treatment increased? Are we getting more kids who have problems?
I think so. I mean, you look at social media, you look at mass shootings, teen suicides. The rate of teen suicides has tripled since the 1940s. So I think a lot of it has to do with weaponized social media, constant stimulation, the 24-hour news cycle, much stronger and more potent marijuana. So all these things are contributing, I think, to teens being a lot sicker and young adults being a lot sicker.
It's frightening. I mean, I don't have any kids, but I have 5 nieces. Audra has 2 kids, and it's really
it's
frightening.
Scary
I
world.
worry about my nieces.
It is.
I mean, even on the we see I've had cases where somebody went to a bar and somebody was spiked in their drink, and it's really frightening stuff. So where are things going from here? I mean, is it going to continue to get worse? Are we ever going to sort of get over this hump and start to see a decline?
Well, people say to me, how do you prevent suicide? And I say the same way that you prevent mass shootings. You have to, one, sort of be vigilant. You have to look for the red flags. And a lot of times the people that are going to see this are going to be the loved ones, right? Not psychiatrists, not primary care doctors or therapists, but the people that know you the best are the people that know your baseline and they know when you're acting differently. And so those are the people that have to say, hey, you're not being yourself. You're not hanging out with your friends. You're withdrawing. You're not going to work anymore. You're not taking care of yourself. We need to get you help. And sometimes that needs to be done forcibly if they can't make that decision for themselves.
Yeah, one of the things I talked to John Hewlett, the drug czar here in Palm Beach County, is this. I mean, he really sort of enlightened me. Because I said, we got to make treatment available to everybody. He said, well, that's great, but you got to realize that it's not the treatment component. Obviously, is key, right? We get them into recovery, but it's what happens afterwards, right? Do they have access to a job? Do they have a support? Right. The follow-up program, and it just seems like sometimes it seems the people that do the best. And, I have a lot of friends who are in the treatment industry, but they're also in recovery. They've been in recovery now for 5-10 years. They are going to They go to weekly meetings. They still have a sponsor. If they feel that
a lot of them go to daily meetings. Yeah.
It's really it's really incredible. So, do you, when it comes to the finances, do you guys work with a lot of insurance companies? How does that all work?
Well, we work with some insurance companies. We are largely cash self-pay. We also do courtesy billing of insurance. So what we see is what many treatment centers see with insurance, that insurance companies do not want to pay. They do not want to authorize. They do not want to pay. That's an ongoing issue. But I think there's a component of that, too, that it really is the treatment industry's fault. As insurance, we always look at them as the bad guys. We look at them as the ones who are hoarding the money and they're not providing the care and they're profiting
Isn't
off
that
of their
true, though?
contracts.
Oh, wait, that's not true, right? Oh, no, I'm sorry. I got confused.
Yes,
right. Okay.
Very true. But many people in the treatment industry have also profiteered to the extent that it's been unethical what they've done with urine screens, laboratories, billing unethically, and they've brought this scrutiny on themselves. And insurance,
they screwed the pooch. They really did.
Right.
It really is. So now we like to talk about bad insurance companies, but the treatment industry has contributed to its own problem. So we work with insurance companies, and we work with the ones that are reputable, will work back with us. But we have many people coming to us with insurance, and we say, I'm sorry, we can't help you. You're going to have to go to an in-network facility. And so it's very difficult for people.
Yeah, I mean, it is. And the only other thing is, obviously, if sometimes we talk to people that don't have insurance, they have no financial resources, and trying to get them into a county facility is difficult.
Yeah, so now you're dealing with the safety net services. All the states are funded with safety net services, but we all know that those are substandard. They're also very few. They're rationed. So people go in, they can get basic detox, they can get a few services, but they're not going to get long-term. Where all the research suggests, the longer you're in treatment,
the better the outcomes.
The better the outcome.
And touching upon what Klay said, it's very interesting, is I can't tell you how many times I've said to some of these, I call them kids because they're younger than me, in treatment, you don't understand how lucky you are to be sitting here. what a privilege it is for you to be in this program. Do you understand how that you're a 1%er? Most of the population could not afford to get treatment in this place, and you are getting help, and you should embrace that because it is a gift, and a lot of people don't get it.
Right, they don't. Especially if they've been a court order there, they feel like the world's against them, and they were perfectly okay on their own.
Right.
But meanwhile, the family is literally falling apart around them.
Right. Because they have no insight. Right.
Because they're in a totally different world. So for the folks who are watching the show, how do they find out about Life Skills? Tell us about your website, the phone number, because
most people they're working with professionals. The large majority, we do have a lot of calls that come into our website, Life Skills South Florida. You Google will pop up.
Word of mouth referrals.
Mostly word of mouth coming from professional referrals. So, like I said, from the survey of the top psychiatric facilities in the nation, 8 of the top 10 we work with closely and get referrals from them. We also get referrals from a lot of other hospitals and healthcare systems, private practitioners, psychiatrists, psychologists.
Well, listen, I was very flattered that you agreed to come in. I mean, we've had a lot of clients go through there, and there's just sort of one that pops in my head, which this individual had a criminal case, and I just remember from the day that I met him and his family, and they sat in my office till, I think that he was there for 8 months. I mean, it was a shocking change. Now, ultimately, his criminal case didn't work out the way we had wanted it, but that obviously, what made it so difficult for the judge was how dramatically different and better he was in the time.
He was a changed person. He had bought in and committed himself and made a difference for himself.
Yeah. Unfortunately, his past ultimately caught up with him and sort of put the judge in a bit of a bind, and really there wasn't much she could do. But hopefully, when he gets out, things
straighten
himself out. But I was flattered that you came in. Thank you both for coming in.
Thank you for having us.
And I'm going to tell them next time we're having a thing, how dare they schedule a triathlon or a bike.
That's right. Bike
especially
race,
when Dr. Boba's trying to get here on time. You know what I mean?
Absolutely. Move that thing to France. It shouldn't be here.
And by the way, if you're going to wear a suit like that, you're going to get mistaken for a lawyer, so be careful, all right?
Okay. I was hoping you wouldn't insult me like that.
All right, folks. Thanks for tuning in. You can follow us on Facebook. We're on YouTube. There's the drugandalcoholattorneys.com website. You can email me, Mark at drugandalcoholattorneys.com. You can call us, 561-419-6095. And also, while you're watching the show, if you have any questions, post it, and we will answer that question. And until next week, thanks for tuning in.